Well, I'm Dr. Jim Del Rosso, a dermatologist in Las Vegas, Nevada, and I'm also the editor-in-chief of clinical dermatology for the Journal of Clinical and Aesthetic Dermatology, affectionately known as the JCAD. Some people even call it the Green Journal. And I'm going to be talking about the May 2025 issue. So I'm sitting here on my lunch hour reading through the issue, and I really am happy to see that we're getting letters to the editor. We're getting them fairly consistently. And one particular letter to the editor that was in this issue is the feasibility of Idiom's clinical framework to optimize psoriatic arthritis care, and it's a quality improvement study, cross-sectional. And it's by authors from, many of them are from Icahn School of Medicine in New York at Mount Sinai. There's one from Harvard Medical School, Dermatology Department, and one from University of Texas Southwestern Medical Center in Dallas, Texas. That happens to be Dr. Joseph Narola, who not too long ago has become chair of that particular department. So this, I think, is a very interesting article. What they did was, first of all, I remember calling a colleague and asking if he was going to be at a meeting, and he said, "No, I can't go to that meeting. I have to go to the Idiom meeting." And I'm like, "What's the Idiom meeting?" And the Idiom is the International Dermatology Outcome Measures Group that meets to look at outcome measures. And specifically, this letter to the editor relates to looking at ways to improve the diagnosis of psoriatic arthritis in patients that have psoriasis. So we see a lot of patients with psoriasis. Not all of them have psoriatic arthritis, but it's a way to try to tease out or find those patients beyond what we might get in just asking a few questions, because the patients don't necessarily equate arthritis with psoriasis, or they might not even realize that some of the symptoms they're having relate to that. So this specifically is looking at two measures: the PEST score, which is a psoriasis epidemiology screening tool. And I'm familiar with that because we've utilized that in some clinics. And then if the patients get at least a 3 on that particular tool, then they could be moved on to what's called the psoriatic arthritis impact of disease 12 questionnaire. So what they did in 26 Mount Sinai dermatology clinics, they integrated the PEST tool. And then, if the patient met the criteria on the PEST tool, they could then go on to take the PSAID 12, or the Psoriatic Arthritis Impact of Disease 12 questionnaire. And what they did over 23 months, they saw a little bit over 7,400 patients. And they actually screened them to find out how many hit some of those measures that they may have psoriatic arthritis. And a certain percentage did, but as it got whittled down, there were smaller and smaller numbers that they would actually get patients that met those outcome measures and then were seen in consultation. But it was effective in helping them identify some of the patients. So I think it's a very good article if you're interested in this. If we can get fine-tuned tools to use in our practice that are time efficient and allow us to detect conditions like psoriatic arthritis, that's what they're working toward. If you're interested in psoriasis, I think this is a very valuable letter to the editor. Now, one of the articles that really stood out for me, because this is an area of dermatology that I have some reasonable familiarity with, but not as much as I would like. And this is the use of checkpoint inhibitors in managing, in this case, cutaneous malignancies. They could be used for other types of malignancies. And specifically looking at inhibitors of the programmed cell death protein, PD-1 inhibitors. This is a review that looks at checkpoint inhibition and PD-1 inhibitors, primarily in cutaneous malignancy, goes through the background to help you understand what the applications are and what kind of data we're finding. With three particular malignancies are covered in some depth. There's malignant melanoma. Malignant is obviously redundant because all melanomas are malignant. Squamous cell carcinoma and Merkel cell carcinoma. It's an excellent article by Darnall and other colleagues, and I think you'll find it very, very helpful if you're looking to gather more information and get up to date on PD-1 inhibitors, which are checkpoint inhibitors used in the management of cancer. The ideal is to shrink the tumor and make them more operable. When you have larger lesions, make them smaller and then make them more amenable to surgery, in addition to trying to help manage the malignancies themselves. Now, there's another article that has to do with one of these agents, pembrolizumab. And it was a patient, a 71-year-old patient, that was utilizing this checkpoint inhibitor to treat a urothelial cancer. So he had of the urinary tract and developed some severe pruritus that was refractory to topical corticosteroids, narrowband UVB, and also moisturizers, some emollient therapy. The patient was treated with roflumilast 0.3% cream once a day, which is a phosphodiesterase 4 inhibitor, and we have that formulation available for the treatment of a cream for psoriasis. We have a foam, 0.3% foam for seborrheic dermatitis, and we also have a 0.15% cream for atopic dermatitis. Three approvals for topical roflumilast, which is an excellent PD4 inhibitor in a very good formulation. This patient utilized the topical roflumilast 0.3% cream once a day and rapidly, within just a few days, saw a marked improvement of the pruritus that had previously been refractory. And that's by Laura Lomax, who is from Greensboro, North Carolina, that was kind enough to submit that case report. Now, another paper that really had me thinking a lot about, because I am currently doing a lot of research studies with hidradenitis suppurativa, and it's a systematic review by Al-Haj and other authors, the correlation between hidradenitis suppurativa and irritable bowel diseases. Now, it's actually inflammatory bowel diseases, not irritable bowel syndrome per se, and it's looking at if there are correlations between hidradenitis suppurativa and patients developing inflammatory gastrointestinal diseases. And they actually found some overlap, which I'm not surprised about, based on thinking about what's actually going on with hidradenitis suppurativa and inflammatory bowel disease. They found that there appear to be some links that create them being comorbidities of each other in the same patient, and that is smoking is a significant factor, obesity, perianal disease, and some genetic mutations, including HLA-B27. So I think this is a very good article to get us thinking about how some of these disease states are connected and maybe helping us find the diagnosis sooner in some patients that may have one of these diseases or another. Now, there's another article that is actually being featured on JCAD journal reviews, and this is tralokinumab as a therapeutic alternative for dupilumab-associated arthralgias in atopic dermatitis, a multi-center case series. And the senior author on the paper, the last author is Christopher Bunick from Yale. Many of us know Dr. Bunick. He does great clinical research and also a lot of basic science research. And he spearheaded getting a collection of patients that had dupilumab-associated arthralgias, and then those patients being treated with tralokinumab to see if they would now have something that can help their atopic dermatitis, which tralokinumab did, but also none of the patients developed the arthralgias that they had with dupilumab. So you could treat the patient with the tralokinumab when they were not able to uh, utilize the dupilumab and effectively control their atopic dermatitis in the vast majority of the patients, and the patients not develop a recurrence of the arthralgias. So That is really important because that's something that will come up sometimes in the clinical setting. Arthralgias, psoriatic arthritis, psoriasis. There are some other entities that have been added to from post-marketing data to warnings to look for with dupilumab. And so we obviously have dupilumab to effectively treat a lot of patients, but some patients do run into difficulties, and tralokinumab represents an important option in those patients that can do two things: help control their atopic dermatitis and also not have the arthralgias redevelop. Now, this can happen early. It could be within a month of starting dupilumab or even as late as 48 months. So it can happen anytime. So it is important to inquire with patients if they're having any joint pains or any joint discomfort. Now, there are a couple of other articles. There is a clinician's guide to dupilumab related ocular surface disease, which actually touches on the surface of this subject for dermatologists, gives some general suggestions. It's by Sandy Asaf, Peter Leo, and myself as the senior author. And it's just a guide to help you with patients that may develop ocular surface disease, dry eye type phenomena that is receiving dupilumab. We can also see that with the IL-13 inhibitors, tralokinumab and lebrikizumab, but this article specifically focuses on seeing many more people have been treated with dupilumab, so the focus has been on dupilumab cases. And as I mentioned earlier, if they develop ocular surface disease or dry eye from dupilumab, they may not necessarily have it if they're switched to tralokinumab or even lebrikizumab. I personally think any patient with atopic dermatitis should be encouraged by their dermatologist or dermatology clinician to see an ophthalmologist, because atopic dermatitis in and of itself has a very high association with ocular diseases, either from the atopic dermatitis or even from systemic or topical corticosteroid therapy that can cause cataracts or even increase intraocular pressure. So the eye is very much involved with the atopic disease state itself as having problems. So that's a significant comorbidity, just like we want to tell our patients with psoriasis, make sure they're seeing an internist or the general care physician or even a cardiologist because of the potential comorbidity of cardiovascular disease. Ocular disease is very common in atopic patients, even unrelated to the biologic agents. I think it's good medical care to suggest that. A couple of other papers: ferulic acid, which is a phytochemical, it's a polyphenol that can be a scavenger to reactive oxygen species and also can help with other aspects of the skin. And so ferulic acid is something that can be in a variety of different topical products. And this is a systemic review of what the benefits of ferulic acid are in terms of the skin. And then finally, skin biome, probiotic topical treatment for patients that have acne-prone skin. There is one particular formulation that is Cutibacterium acnes, the subspecies defendans, and it applies this once a day, and it was done in 136 patients from 5 centers, both males and females that were adults between the ages of 18 and 40 years, and utilized over 8 weeks. And they looked at acne lesions and saw improvement, but also the overall health of the skin, the healthy integrity of the skin, the appearance of the skin was improved. So this is another way of looking at utilizing a probiotic skin biome directed therapy that can be also helpful in acne patients. I think it's interesting reading. We're seeing more and more work on looking at different uh, subspecies or species of microorganisms that may basically crowd out the pathogenic organisms, and there the patient is going to improve. So that's a wrap. I hope the Journal of Clinical Aesthetic Dermatology is a journal that, when it comes across your desk as a hard copy, or you get the digital edition in an email, that you look at it and benefit from it because we're all working very hard at JCAD to bring you very valuable publications. Thank you very much.